especially fun. It's especially fun when we're able to have people who are from New York City. So we are going to be talking about moving beyond stigma, addressing mental health using community resources. And as a reminder to those who are new to our social medicine rounds, we are holding these rounds because we want to be in conversation. You can see our previous rounds if you point your camera to that QR code and follow it over to our website. But our social medicine rounds for us are really an opportunity to connect our staff, our faculty, our trainees, and really, most importantly, our community members to leaders who are discussing medical, economic, and psychosocial issues that impact the health of our Bronx community. And we've had a number of topics that we focused on. And one thing that's very exciting about this is that a lot of this is community-driven and community-led. We had community members reach out about wanting to talk about the criminal justice system, and specifically Rikers and its impact on the Bronx community, and we held those rounds. And recently, we had Paulette join us, who is a member of the Social Medicine Rounds Committee, join us and say, I really think we should hear from this group that's doing some really excellent mental health work that we should all hear about. And so I say this because I want to encourage those of you that are listening, especially those who are Bronx residents or Bronx providers, to please think about any issues that really feel like they are important for our community and important for us to consider to be able to continue to drive these conversations. So I'm going to turn it over to Paulette to go ahead and introduce our speakers.
Can you hear me?
Yes, we can hear you.
Okay. Great. It's my pleasure to introduce our speakers this evening. It's Faven, Araya, MPH, DrPH. Faven Araya is a dynamic and multifaceted leader, researcher, and public health advocate. She serves as the Community Engagement and Relations Manager at the Arthur Ashe Institute for Urban Health, where she manages the Institute's community engagement and research initiatives on mental health, cardiovascular disease, HIV/AIDS, and the social determinants of health, among others. She also leads Communities Together for Health Equity, a city network of over 70 community-based organizations working to address these social determinants of health. She received her Master of Public Health in Epidemiology at the Icahn School of Medicine at Mount Sinai, and is currently pursuing her doctorate of public health at SUNY Downstate Health Sciences University. Mr. Humberto Brown, MA. Mr. Humberto Brown is the Director of Health Disparities Initiatives at the State University of New York Downstate Medical Center in Brooklyn. In this capacity, he is assigned as a loaned executive to the Arthur Ashe Institute for Urban Health and the Brooklyn Borough President's Office on Community-Based Participatory Research. At the Arthur Ashe Institute for Urban Health, Mr. Brown trained high school students to understand the role of culture in healing and to acquire the human relations tools necessary for delivering healthcare to a multicultural clientele. He also serves as chairman of the Committee on Underrepresented Minorities in Medicine of the Community Coalition to Increase Diversity in the Healthcare Professions, a coalition committed to offering a community-grounded voice to this issue in New York City. Welcome.
Pleasure.
Thank you. Thank you, Paulette. Welcome, Faven. Welcome, Humberto. We are so glad to have you. I'm going to go ahead and turn it over to you guys if you want to upload your slides, Faven.
Okay, can you see our slides?
Yes.
And can you hear us okay?
Yes.
Okay, awesome. Thank you so much for having us. Thank you, Paulette, for making the connection. We are very excited to be here and to share the work of the Institute. And so I will let Humberto lead the way.
Hi, again. This is a pleasure for us to share our work, what we do. We always think that collaboration and sharing experience is a very good strategy to strengthen our capacity to intervene, providing the type of health and improving the health system that take care of our complex community. So we see this as a very important strategy of collaboration to kind of find in common ground intervention. The Ashe Institute, as you probably have some background on us, was created by Arthur Ashe before he died, well, 30 years ago. And Arthur, even though he was a very famous person and probably well off at the time of his death of HIV/AIDS, that he got through a transfusion of blood because of his cardiovascular situation, was also an activist and left his name with an institution that was grounded in the community, Brooklyn, trained physician and public health people that he think address those communities, because his experience showed him that the system was unequal. With all his knowledge, power, connection, he didn't feel to get the appropriate care, and he could see the absence of people of color throughout the professional system. So that's the background of the Ashe Institute. When we were created, we did a lot of intervention of individual behavior, changing health literacy, again, responding to the historical moment of addressing community needs. So the way we describe ourselves, I think, tell you a lot of our concept of work. We utilize a model of community empowerment and engagement to promote health equity and social justice through strategic partnerships, innovative community-based health promotion and research, and the preparation of a more diverse and inclusive workforce for health professionals. When we describe this, I know for a lot of, at least for me, these words are used a lot today. These concepts probably inform a lot of strategies and document. For us, this emerged out of practice, working in communities, trying to address some of these systems that are persistent in the way our community end up the kind of negative outcome. So we found the issue of community engagement essential one, that you cannot design and create programs. And from the beginning, when they start to address health disparity, every 5 to 10 years, they realized that they were unable to implement these strategies. And the missing, one of the most fundamental missing factor was a community engagement, community voices. So we believe that community empowerment, community engagement is essential. And we don't say it just as a slogan, but it means that the way you engage community, the incorporation, the collaboration, the equity in decision-making and participation and designing become an important factor. It's not just a slogan, but how do you do it? People use the term, how do you implement this, become a challenging question. Promotion of health equity and social justice, which is also used very much today, is an evolving term that comes from activist world, that come from a lot of social justice movement that today has been incorporated in the health field, and this is a victory. But health equity is a tool to understand, is to address or to measure outcome of addressing inequalities, of not only measuring health outcome in sense of disease or sickness, but systems and structures that would allow the issue of speaking about health equity, that meaning different population get the appropriate intervention, the appropriate care, and the appropriate treatment culturally and otherwise. And social justice, obviously for us, is a lens that if you recognize that there's social determinants of health, and these systems of oppression, racism, xenophobia, immigration status, then you have to have a strategy that talking about justice, because these systems create unjust system. It create a negative outcome. And so we also, when we put those terms there, it means something in our approach to addressing these issues in healthcare. So I just wanted to unpack that so you understand some of the way we do things. And the issue of the workforce is the last one there before we switch to some of this data, is that When one of the things I mentioned about Arthur Ashe, the issue of the workforce. For those of us involved in healthcare for a long time, we know that the numbers change very little for a number of minorities or people of color in the health profession. If it's for doctors or nurses and all the other health profession, the numbers continues to be low and not representative of the population, the proportion of population in the general population. In medicine, it continues to be 8, 9, sometimes even lower. Nurses, the same. So one of the things we did responding to Arthur's, it was to create our science academy, which we could talk another time about it, which was to create a pipeline that start addressing the roots of the problem, which from the fundamental of middle school and high school, and using these to expose these young people to what it means to be in these different health professions. So we can move on. Why our work matters, I mean, we list here some of the factors that kind of guide us. That the Surgeon General declared youth of mental health crisis, I think is in line with most of the crises that have been declared for the last 20 years and disparities in health in the community of color, right? What we think is important, what we mentioned that is that it's hard to get policies. Sometimes it's hard to get collaboration when something is not official. We went through that with the COVID-19 crisis, where it took both the presidency and CDC to make some official decision of what we were facing. The longer you wait to declare something, the longer you identify, the longer it takes to prepare intervention policies or strategies. We know that because of the racism, because of a system, long history of the system of inequality in this country, that people of color, right, suffer the worst outcome, have the worst outcome in that system. We know also following that this suicide rate for minority of color, community of color, African Americans, Latinos, and other immigrants are going to be higher. And between those ages of 15 and 24, that helped us define who we were working with. That 40% increase among high school students reports, sad feelings, impacted of sadness. I just saw something just 2 days ago, and this situation continues to get worse as we monitor and see kids, the number of kids who identify sadness and hopelessness on a daily basis have increased dramatically after the COVID-19 experience. Self-reported suicide attempt rose nearly 80%. More than 64% of youth who suffer from major depression in our community receive any, if any, very little mental health related treatment, or will work with these community, sustain that, validate that. How many kids even don't know how to describe it and who to talk to when they feel that way. And for us, following what I said earlier, we always understand that if you talk about health beyond the illness, the disease, you have to address the social determinants, the roots of things. So one of the issues of this agreement with the collaboration with UNICEF was significant because UNICEF do a lot of work around the world. They address, they've done major projects. I do international work also, so I collaborate sometimes with other projects with Palestinian population. They've done a lot of work in different African countries. I'm from Latin America originally. We've collaborated, we work with them in other areas of Latin America. But one of the things that Brooklyn and New York and probably some other metropolitan city has is that it brings a diverse community from different parts of the world, located in the same places. And now we have to address those multiple sectors. So our population, not a single population, not just white population, but multiple factors that affect how these population suffer, what is the history of their suffering. We know in the US from slavery, in most of these countries, colonialism is a big important factor. So we take those things in consideration when we're treating people, not just the disease that they have, but the social, economical, cultural context with which we relate to them. And the last point there is what COVID-19, the impact of COVID-19, how it exacerbated these existing conditions. For all of us who work in the field, we know how tremendous and challenging it was, even just for the Department of Health and other institutions to reach to some of the multiple ethnic and racial community in New York, from the Chinese to the Koreans, to the multiplicity of the African countries, in Senegal, Ghana. I mean, it was just multiple sectors that now you had to have an approach to reach out to those sectors. I would pass it on to Faven to talk a little about the model, but I just want to contextualize what we're doing. I want to mention that those statistics and those numbers that we just mentioned, the way we approach them is that we see statistics and numbers as a photograph. It says the outcome of system of oppression. It says the outcome of way people are treated. It doesn't address always the roots. It doesn't address the system. It just tells us something. A friend of mine who work in statistics, critical view of statistics, always says that statistics just show you the number. It doesn't shows the pain. It doesn't reflect the blood. It doesn't reflect the history. So one of the things we do is try to bring that alive. What does statistic mean in reality with this population that we work? We have done different aspects of health work in Brooklyn, but this is a specific population that we work with, I've collaborated with, and it was challenging for the factors I said before. Are we talking about a multicultural community? We're talking about people from different countries, different language, different culture, different religious practice. We're talking about people who come from different gender, race, experience. We're talking about people who come from war zone countries. We're talking about people who have gone through a difficult immigration process to get here. We're talking about people who were tortured in war zones, children of those people. So we understand those things, that there's not an easy one size fit all. So that collaboration brought with us, the part of the model, it was to have consultants that had managed some of UNICEF international global projects. So we share experience from our local experience, which is kind of international, with their broad experience. So if Faven want to share some of the approach, and then we can share some of the practice and experience that we have with these young people. Thank you.
Thanks, Humberto. I think one of the things that you highlighted at the beginning of this conversation was that what the Institute represents is what we do in practice. And so the statistics that you just highlighted are numbers that I think a lot of people may be familiar with. It's highlighted in literature and reports. But what the Institute wanted to do was to conduct a thorough needs assessment to be able to integrate the voices of communities to understand what the realities were on the ground. And this is coming as a result of the pandemic. At the time of this project, this initiative, it was at the height of the pandemic when we knew that people were really suffering. Social and economic conditions were exacerbated. Schools were closed, people were doing remote learning. So we knew that our community was really struggling. And the literature and the reports were not able to capture that in real time. And so we launched this community needs assessment, gleaning on the literature and what that had already told us about the communities that we serve, but then wanted to speak to key community stakeholders who were immersed in the community, who understood what was going on. And so we started our process with holding key informant interviews with pastors, with school psychologists, with barbershops, with barbers and stylists, with educators, with parents, and with youth. And those key informant interviews allowed us to kind of get the lay of the land. What is going on right now? What are some of the things that people are struggling with? And because our initiative was focused around addressing the mental health and psychosocial needs of youth, we knew that we needed to speak to youth. And so the next step was us holding focus groups or community listening sessions with youth. So our key informant interviews were with 11 community stakeholders. We held about 11 5 to 7 focus groups, reaching about 70 youth. spanning from ages 12 to 24. And we had small community listening sessions with these youth to understand what their experiences were. What are your lived experiences? What is your understanding of mental health? What are your coping strategies? What resources are available to you? What resources do you know of? What have been your experiences accessing those resources? And then we wrapped that process up by launching a rapid response survey. So we had these key informant interviews that gave us this really nuanced response of what was going on the ground, followed up by focus groups, but we wanted to capture a wider net of folks in the community. And so we launched this rapid response survey, and we had reached about 160 participants. And that collective process allowed us to develop a strategy to design an intervention that we thought was going to be responsive to our community's needs. And since the Institute focuses on access to health education, that's what we focused on. We knew that mental health was such a highly stigmatized topic. It was something that was not discussed in our community, that what we needed to do was just break the ice and begin having conversations around mental health. And so our needs assessment informed the development of a culturally tailored mental health and psychosocial support curriculum. And we had developed this curriculum in twofold. When we had done our focus groups, we had asked our youth, like, when you are in a challenging moment, who do you lean on for support? And 9 out of 10 of them had said, my friend. And I don't know what you guys know about the average 12, 13, 14-year-old, but they are not in a position or have the capacity to be able to navigate themselves, let alone somebody else, through a mental health challenge. And so we knew that what we needed to do is have community health education workshops for people who work with youth so that we could build their capacity to be able to support youth. But then we also needed to have a separate strategy that was focused on building the capacity of youth. And so we held peer-to-peer training sessions. And I'll talk a little bit more about that later. And so we launched these 2 workshops. Our community health education workshops were in various settings. So we did them with educators at schools. We did them in barbershops and salons. We did it with community-based organizations, with LGBTQ communities. We did them with churches. And so tapping into these settings where we knew that people of color naturally congregated, and where information was shared and exchanged. The second part was identifying 20 peers who we thought we could develop into peer leaders who could facilitate their own workshops, right? So peers educating peers. And then the last piece, of course, is evaluation, understanding how effective the strategy was. And so those key community needs assessment findings were really important to the development of our intervention. And we kind of captured 4 themes: lived experiences, sources of stress, barriers and challenges, and coping mechanisms and access to resources. And starting with lived experiences, we already knew that poor socioeconomic conditions existed in our communities. We know that they were low income, we know that they were immigrants, we know that they were people of color. And as a result, we know how structural determinants influence those communities and those neighborhoods. But what we also found out is during the pandemic, those communities who were already experiencing those challenging conditions, those conditions were exacerbated. And so people who were already struggling financially were now losing their job. They were now having to struggle to find access to basic necessities, food, paying your utility bill, childcare, things of that nature. And we also know that students transition from in-person learning to remote learning. And so as a result, these kids were isolated in their homes. We knew that these homes were already small. You guys know how New York City living is. And so these homes are crowded. You now have 3 or 4 siblings who are trying to be taking their classes on Zoom. They're sharing spaces. And so this ultimately led to our youth feeling a lack of motivation, feeling bored or depressed, feeling challenged with quarantine. We knew that the family dynamics within those households were not always ideal. And so if you already have issues of domestic violence, or if you have issues with kind of hostile home environments, those things are going to be exacerbated when you're all quarantining together 24/7. So sources of stress, primarily for youth, it was the transition to remote learning. They were no longer socializing with their friends. They were no longer in-person settings. They were no longer being taught by a live teacher. All of these challenges that come with transitioning to remote learning. And while kids are apt to technology, doing school on a computer screen was not ideal for many of these kids. And then because we knew that most of the essential workers were communities of color, we also heard from youth that they experienced fear of their family members being exposed to COVID and being hospitalized and dying. So they were dealing with this added layer of stress, knowing that their parents had to go out to the field to continue to provide for them. Barriers and challenges. I'm going to lean on Humberto or perhaps my colleague Kenya to talk about the barriers and challenges and perception of mental health. Humberto, do you want to talk about that and some of the stigma, gender-based expectations?
Okay, yes, sure. I'll share some if I can want to. This was very significant because for those who do work with young people, just to establish a relationship with them, just open them, exactly a friendship with them is a process, takes time. So some of this work that we do is hard sometimes to assess in relation to getting stuff done according to a timeline that was designed, because you learn early that is relationship building, and that relationship building going to define in a way how you move forward. What we learned in many of the conversations, we spoke about kids who are from immigrants community or from poor community, is that there were some areas that were both barriers and was great challenge for them. For example, the kids who spoke about their parents not understanding them according to the parents' values, right? That their immigrant parents who have worked so hard, who have done a lot of different things, and they don't understand why their kids are feeling depressed or not motivated. They don't really have any problem. They're taken care of, they pay, they have a place to live, they get allowance. So a lot of the kids spoke about that their parents only think in other ways that they're okay if they have all the material needs. One of the kids, I asked him once, well, when you speak to your mom, what does she say? He said, well, my mom asks me if I'm doing well for the things that she's concerned about. If I went to school, that I did my homework, and 4 or 5 things. She never asked me any other questions. So for her, I'm okay in those settings. It was very interesting, that conversation with that kid, because I think the parents are separated. And I said, well, what your parents, your father. He said, well, my mom treat me like I'm a permanent child, and my dad wanted me to think I'm an adult. So I negotiate with them in these 2 other aspects. So you could see we knew after this experience that we had to find a way of talking to the parents, creating an understanding where the parents are coming from, and making the parents sensitive to some of the things that the youth was sharing with us. And this wasn't only, and when we talk about culture and we talk about gender and we talk about these factors, sometimes we mention it, but this is a real world. When you talk to those kids, you hear from them why they don't trust, why it is a factor, who they think understand them or don't understand them. That came out a lot with kids who felt not understood about sexual orientation, that not understood if they weren't the macho male strong person for the father. Was a lot of these things came up, but after conversation and building trust with them, I would say other things that they share in that structure with each of schools. We try to find out, how they felt at school. Do they believe that at school they get the kind of, if there was sensitivity to their emotional wellness at school? And they share very interesting stories. We were trying to do like a mapping of the school to see which one have social program, if they have nurses, what kind of health system or support system exists in the school. And when we asked the kids, the same thing way we asked them about their peer and friends who they trust, it was surprisingly, they say that, I said, would they prefer to speak to a counselor, mental health, or the teacher? I said, well, we normally try to speak to the friendly teacher, who is nice to me and always speak to me, because when I go to the counselor, already I'm labeled a problem. I know I'm going there already called a problem. So that was very interesting in sharing who they trust and who they don't trust. But it also identify that they spend a lot of time in school, and that at school, it was necessary prior to work with the school system, with the teachers who teach these kids, who work with them, who spend a lot of hours with them, to see if we could find common ground of understanding their live experience, what they're feeling, and some of the expectation that they had. That I think those are some, just for time, some of the many things that these kids share.
Kenny, do you want to highlight some of the coping mechanisms and resources that we heard about?
Sure. As Faven mentioned before, we did have a lot of these workshops and just these conversations in different sectors. And one of the peers, and just even the youth that we spoke with, sharing that they wish that, for example, how you have confessionals, and the pastor listens to you and not really have anything to say back to you. Like, they wish that there were trusted spaces that they could have these conversations. They also spoke about how some of their peers as being the primary sources of support. So as Faven mentioned, we really wanted to build the capacity of youth. We also heard, just going back a little bit in regards to like challenges, we also heard a lot about suicide, and even some of the youth sharing that they had friends or, loved ones that committed suicide, and unfortunately not knowing how to navigate that. So in regards to coping and mechanism, we really wanted to make sure that we equipped them with resources in their community. As Humberto shared, them sharing that sometimes they going to the guidance counselors, they have this stigma of like, oh, if you're going to a guidance counselor, you're in trouble. But they wanted to have more spaces where they could just talk and conversate and talk about some of the nuances that they were going through. In regards to like just multiple points of entry for support, we really wanted to make sure that we were speaking with grandparents, parents, teachers, all those, the village that really take care the young person overall. And also when we worked with a lot of the churches, a lot of the youth, we're very thankful for just having these conversations between parents and the elders and things like that in the church institutions and things like that. So in regards to coping and resources, a really, really big push was just to make sure that there were trusted spaces to have these conversations free of judgment. We always went into these conversations with just setting some of these ground rules so everybody have a feel free to have a conversation to speak.
I think as you guys are listening to these experiences, whether you're providers, you guys are healthcare providers in training, or you're in public health, it's important to recognize the multiple identities and intersections that a person may come to you as. If you're a clinician and you're serving a patient, these lived experiences, these sources of stress, they manifest in different ways. And so you may be seeing a patient who's coming in dealing with poor health or dealing with chronic stress, but they're coming from poor socioeconomic conditions. They're coming from feeling stigmatized and those things. So I just think it's important for us to be able to have an understanding of the multiple layers and complexities that people are coming to the table with. And that's understanding those things is how we design interventions that are appropriate.
I wanted to share, I know we try to time, but I think it's important also because we use this concept of culture all the time. And that culture matters, and matters for all the work that we do in many different areas. Cultural understanding is important. Like, one of the things that was a great breakthrough with young people, a lot of them from the Caribbean immigrant parents, others since I'm from the Caribbean, and relate to multiple of those identities as my family, just breaking through language-wise, if it's Spanish, if it's Creole, it's just some of those things were so important because they would just laugh and say, you sound just like my grandfather. My mom says the same thing. I would just trigger things to them that I know that in their families, it's probably the conversation is the way they feel. And it really, taking culture and make it a reality was important from a place of not stigmatizing them. Because I think I do a lot of, at Downstate, I did a lot of, with medical students and other health professional issues about understanding culture and working with them, with the communities. But one of the things that you learn as Faven just mentioned, some of the health professional, sometimes we walked in the room with our own biases, with our own problems, and we don't do self-check. Working with these young people are very important to do self-check, because at some of the models I've seen of community, of teaching doctors and other health professionals to address the community, the model stigmatize the community. We ask the community to speak about their food and their language. And then somehow it's like if the community, those practice that is not standardized, mainstream, middle class, or certain sector standard, there's a problem with that, right? And many times when we used to do that work, the community will react. Like, well, this is the way I do things or see things, differently. I just think I wanted to call the attention when we talk about culture, that is also culture of the institutions and the people who work with those communities that can become an unsafe space. It doesn't send the message of solidarity. And the other factor that I want to include in this is that we realized that we had to have a very intersectional approach too. It has to be intersectional for the complexity of the community. One identity, one experience, one intervention doesn't resolve the problem. We don't understand the complexity of that person and group experiences. And same thing for multiple systems that impact the outcome of these kids' health. So these are other factors that we bring with us as we approach and collaborate with UNICEF.
So Humberto, I think you bring up a good point. So what did this culminate in? It culminated in over 25 partnerships, because we knew that the communities that we had different identities, had different intersections, had different religions. And so it required us partnering with different institutions, different businesses who serviced those communities. So we worked with barbers and stylists, we worked with faith-based institutions, we worked with LGBT communities. And so partnerships were critical for us to be able to reach those different communities and hold multiple workshops. So we held over 20 workshops and we engaged over 650 people in those workshops. And one of the things that was really, I think, critical to our work related to what Humberto mentioned was the fact that we had a tailored approach to each workshop. So if we were working with people, the curriculum was the same. We enlisted health educators, us, to facilitate, and the workshops were co-facilitated by mental health providers. And so if we were going into a church, we needed to have a mental health provider who was familiar with religion, who understood the role of spirituality in people's decision-making and their perception of mental health. If we went into LGBTQ communities, we needed to tailor the workshop to be able to address to their unique needs, right? So everything, while the curriculum was standardized, the facilitation was tailored depending on the audience. And we enlisted local assets of mental health providers who were from those communities, who understood those communities, who could speak to the unique needs of those communities. And so we implemented an evaluation using a theory of change conceptual model to understand what did our intervention do, how did it make a change or make an impact in our community. And we used a mixed method evaluation, utilizing key informant interviews, focus groups, and 3-month follow-up surveys. So at the end of each workshop, our participants completed a survey to assess their experience with the workshop, things that they may have learned. And then we did a 3-month follow-up to kind of assess more of the long-term impact of those workshops. And this was inclusive of community partners through every stage of the process, through the needs assessment, through the development of the curriculum, and through the evaluation of our intervention. So these are some of the just high level outcomes. The post-workshop evaluation, we had about 148 youth. So we had about 300 youth and about 350, because we had two different modules. Of those, 98% reported increased knowledge of mental health and wellness, 94% increased awareness of their own mental health and wellness, 84% felt more confident having conversations around mental health. So how do we begin to destigmatize it is by people feeling comfortable and confident having these conversations. And 95% felt the workshops gave them practical skills to address mental health. So it's also us equipping them and enabling them to be able to proactively address mental health and wellness. And outside of those statistics, the partnerships were key. So the Institute already has a pretty wide and diverse range of partnerships, but through this initiative had established 14 new partnerships. And so part of the work of this project or this initiative was to strengthen community networks. And by establishing partnerships, we were able to strengthen their capacity to be able to provide mental health workshops or education or resources, even if that wasn't something that they normally did as part of their programming. And I think just as important as statistics are community voices. And so these are some of the quotes that came out of our evaluation of how our youth in particular had responded to the workshop. So these are youth who not only participated in the training to become a peer leader, and these are also youth who participated in the workshop. So we had a couple folks say, I handle my mental health differently and learned to make more time for myself and to not overburden myself. I've been able to promote self-care in my workplace. I'm able to control my emotions much better. It has gotten stronger through meditation and balance, and just affirming that it's okay to reach out for help from friends or family. Here's another quote from our CBO partner. So as we think about those supporting youth and strengthening that network, here's a story about our CBO partner who works with youth and had a youth that's high risk who participated as a peer leader. And she had texted her youth leader saying, what am I supposed to do again when I can't take it anymore? Do you have the information from the Arthur Ashe? And the CBO leader said, I saw that she was now conscious that there was a tool or a mechanism, right? So this intervention is not a solution. It's not a one size fits all, but it is a tool that people can utilize in moments like this. And so at least she acknowledged that she's in a place that she's not okay. So she recognized that she was not in a place that was okay and was able to reach out to somebody for support who deferred her to the tools and skills that she had learned during the workshop. So lessons learned that we had, that are key takeaways from this initiative is establishing a community needs assessment using a mixed methods approach. So you need to have both community voices captured as well as quantitative data that are driving the design and development of interventions. Grounding interventions on communities' realities. It's not enough to just look at the literature. That's just the start. But being able to go to community stakeholders who are on the ground, who are immersed in the community, who understand what is going on today, not 10 years ago, but what is going on today. Establish a plan, but be flexible to adapt and modify process to respond to community needs. So this happened quite a bit throughout our process. We didn't develop an intervention and say, we're going to launch it, we're not going to make any modifications. We needed to adapt and tweak things along the way. We needed to have a facilitator for this setting. We needed to expand our workshops to address this community. So establishing a flexible plan is really important. And then key is partnerships, both new and old. If we're thinking about having systemic changes, we have to have all levels involved. And so it's not enough to say that the Institute launched an intervention and it was effective, but how do we involve other community members, other stakeholders, other institutions to be part of that change? Sustainability is a critical piece of this. And so we automatically, as we learned that this was a intervention that was responsive to community needs, that was well received, we had thought about sustainability. How do we ensure that this continues to be a resource to our community? How do we ensure that these conversations continue? And one of the critical pieces that we had learned is during our peer-to-peer leadership trainings that 1 to 2 training sessions was not enough to say a peer is now equipped or positioned to be able to serve as a mental health advocate. And so following that initial project, we launched a mental health and psychosocial support peer leadership training program where we had a 6-month intense kind of capacity building training session for 11 youth, where they now were able to learn all the intricacies, not all, but a lot of the intricacies of mental health. Where does it come from? How does it show up? What role can you play in the community and setting that you are in? So a lot of students have felt, well, I'm just a kid, like, what can I do? You can change the dynamic in your home. You can change the dynamic in your schools. You can change the dynamic in your communities, but it was important for them to feel empowered and to see the different spaces where that could happen. And so we just wrapped up this program and are gearing up to launch a more robust mental health and psychosocial support program for the next 2 years. So special acknowledgement to UNICEF. This was their first domestic mental health related initiative in the US. And they played a critical role in designing and evaluating our program. I know that we may not have a lot of time now, but I just wanted to open the floor for any questions that folks may have.
This was excellent. Faven, thank you so much. Humberto, Kenya, thank you so much for taking us through this. What really stands out to me is how real this feels. It felt like you were really immersed in the community and letting it be driven from the community perspective. And that's something that's often spoken about and thought about, but is very hard to do. We normally kind of save our asks for the end of our conversation, but I want to lead with the ask because this work is excellent and needs to be supported. How can places like Montefiore and individuals like the folks that are on the line, ranging from trainees to community members to faculty, how do we think as an institution of offering institutional support to work like this? And then again, specifically, how can clinicians, medical students, and others offer kind of individual level support that maybe falls out of the institution?
Humberto, do you want to go first?
Sure. As you all know, this is a very complex, the issue of partnership.
Oh, you're muted, Humberto.
One of the things that strengthen our work is the structure that we have, right? We are an organization, have a partnership with an academic institution, Downstate Medical Center. Within that, we also created and are the co-director of a health disparities center that is focused to making sure that community voices are engaged in research. So it also allows us to shape and inform and challenge people to have a different approach of how you do research in communities. And the third leg of some of our work is that we also have a partnership with the Brooklyn Borough President Office. They're part of the Disparities Center. And with the Borough President Office, we work on a lot of issues of policies, the kind of policies that we discuss with a lot of the legislators, with some of the institutions that in Brooklyn. So one of the things that we do is continue to establish partnership with the sectors that impact these communities. And I think that's a very important factor, that the institution looks for partnership that give them a more sustainable work. What we have, the other part of this work that I think is essential is policies. As you know, the only thing that gives something long-term and sustainability is getting policies, right? Policy extend program, makes it integral, right? Do systemic changes. So that's what we work with many other organizations who work on policy issues. We do a lot of advocacy, for example, with the Department of Health, both state and city, with issue of policy, right? Not only you encounter these things, and community always ask you, how this is going to change? What you going to do next? How I know that when I get to the hospital, things going to be different, right? You're telling me I should do this. Can you change those oppressive systems that impact my life every day? And that's one of the things that these young people ask us a lot of questions about. What's going to change if I change? Would the school treat me differently? Is my parents, right? So they push us also to, no, don't blame me, I can change, but can you do something to make these things that impacted? So my lesson that we need to also ask the institution to broaden the partnership. For somebody, I'm a faculty at Downstate, so I know some of the issues that we have fragmented way of teaching and practicing medicine, right? So that's another issue that we need to address. I said before, when you speak to health professionals, both doctors and other public health and other professionals, they do not always get training in how they approach community, to work with community. If you go to a community, and we have had, I give you an example where at Downstate, they used to have orientation to the medical students. And one time they were into trouble because a group of medical students wrote a very strong letter to the dean and the president, complaining that the orientation stigmatized their communities because they were from Brooklyn, they were from that neighborhood, their uncle and their mama from that neighborhood that you call dangerous. And that meanwhile, you talk about people could do research, you were stigmatized. And it was a major crisis because they're saying, you're stigmatizing my community. Same thing happened with the Muslim community, right? The whole issue of assumptions. And they brought those questions. So I think that another issue is that when we look at teaching curriculum, we have to look not only at how we address illnesses, but how we address the population. You know, I give you an example and I end with, we did the Disparities Center. We had a major grant from NIH to work on cardiovascular disease and issue of health disparities, right? And we were doing it with fellows in cardiology. I was one of the people teaching. And what was interesting is that the specialists, the first thing they would say, as we do in most of our country, in our society, I am not a racist. I am not homophobic. Everybody declare themselves the best human being. So therefore, you're not aware or conscious as what you bring into the room. And what was interesting, some of them were foreign doctors, right? From India, other places. So when I take care of the heart, you know, I don't mind the person. And I asked them, did the heart walk in the room alone? I've never met a heart in an emergency room or somewhere that walked in alone. That left the person, the history, the experience outside. It's an integral part of people's existence, right? So my heart depends where I'm from or it works, what was previous. So those are the kind of stuff I think that we have to start ourselves, looking at the way we teach people to practice medicine, to relate to people. If you have stigma, I do this a lot with the medical student now and the other professional. If you are homophobic, if you don't recognize that they're transgender rights, you cannot be a good doctor because you're going to impact the way you treat a person, what you do for them is going to be impacted by what you think politically, ideologically, and culturally. So I think that's one of the important things of academic teaching institution to also look at their curriculum and the way. And the last thing I would say is, and I did this when I did a lot of mental health work at Harlem Hospital, is that the professionals don't question their values, right? We do a lot of questioning. We ask we talk about the patient. What the psychiatrists think about their patient? What the social worker? Because they're free of biases. So if I'm from a Latino community, how many Latino community get stigmatized, the description of this emotional woman or the aggressive macho man, you start out with an assumption. So every behavior, you interpret it differently because you started out in a different space. So these are things that you learn of, but I think it's important for the work that you're doing that we integrate that. And obviously the elephant in the room is intersectionality. Everybody's talking about it. It's very hard, both for design of research as to develop programs of intervention, because people don't exist in one category of identity. You're both immigrant and minority and could be gay or transgender. How do I bring those things and assess it if I'm recognizing that the World Health Organization for more than 20 years now recognize that social determinants of health is responsible about 60 or probably higher % of the outcome of health care. So if we say it, how do we integrate it in our approach? From research to intervention as treatment or program. We work with a lot of hospitals at this point with health and one of the things that we do is take these experiences and tell the hospital, if you want to improve, you need to address these things. You need to recognize it. You need to collaborate with this community if you want to have a better outcome in how they're treated. Because if you don't, the outcome will remain the same. If you have what we call mixed community and a Latino community and an African immigrant community, you have the same family with citizen, permanent residents, undocumented, unknown. So when you're dealing with that family, you need to integrate your concept, because during the pandemic, I can tell you, a lot of the Latinos family didn't go to the hospital. They were fearing that their undocumented family was exposed, that immigration will follow them or they will find something out. These things are very real and serious. They're not just in articles. So I think the more we integrate them and we think about them, we probably can improve the systems that we use to approach both inequities and health disparities.
That is a whole sermon. Faven or Kenya, would you guys add anything?
I mean, I'll add just a small sliver to that. In that the model that we do at the Institute is one that can be replicated, right? This is not something that's unique to the Institute. And so what I would recommend is that you leverage the model that we have to understand community needs and to design interventions that involve the community. So if you're dealing with a patient population and you're trying to resolve some type of issue, that you identify opportunities for them to be a part of the conversations or part of the decision-making process so that you can develop things that are responsive to their needs. So yeah, I would say our model is meant to be replicated. And I think you just have to tailor it to the setting that you're in.
But I think just to challenge you a little bit, a big part of that replication is the reality that you guys were able to get resources from UNICEF. And that seems like it really did create or permissioned a lot of this work to go forward. The ideas are there, the work that was done was exceptional, but that resourcing is often the place that folks get stuck and that, health system gets stuck, community members get stuck. And I'm curious about how we think about resourcing. Does it feel like part of the success of obtaining that UNICEF and other big level grants like that is because you had those ties to an academic center? And if that is the case, how will kind of a community-led, right, group that doesn't have those academic ties really think about what it looks like to resource to be able to do this work?
Well,
So
I'll let you allow you, but I think you have to be careful. Community academic partnership is very complex, as you know, right? So sometimes because you're a partner, you don't get certain resources because you're tied to an academic institution, and the assumptions is that you're well-funded, when normal is not that way, right? But the other aspect of that is, we do a lot of community collaboration, and that's why we created networks. We work with networks, and one of it, and Faven could talk more. So what we realized, the same thing that you just said, that one of our work had to be strategy of advocating for equity in resources for community-based organization. And that's why we created CTHE, the community, when there was a district process, because most of these design exclude communities. So we've been involved in advocacy for funding for community work as an essential part to addressing health disparity. If anyone wants to share a little more about that, but that's part of our strategy to find appropriate funding to sustain this type of work, because you're right. The work is fragmented because after each project, you're out without resources to sustain no matter how great the design. But the last thing I would say, though, that we also had to learn in community work, some of the collaboration, is that community also have to be courageous. We have to be honest and courageous. That's one of the things that when you work with young people, they call you out. They want courageousness. Community of color look through. They can see all the games. They see all the bias. They look you straight in the eyes, and they want to make sure that even though you come from that academic, when you go in there, you speak in their behalf and you're honest. Community trust depends on how you treat them, what you do with them. They can see through you. And sometimes the community-based organization take on too much academic identity. They speak like them, they act like them, they design like them. One of the things that the other part of our work that Faven spoke about is designing legitimate, autonomous community approach from their voices, with their experiences. And a lot of the academic institutions has thanked us for that because some of them were too comfortable. And we have to make them uncomfortable with the regular model that doesn't incorporate community. So sometimes it's a very hard, but you have to do it. You have to be courageous enough. And the setting that we work in, barbershop, they tell you, are you going to go and talk in my behalf? Are you going to raise hell in that emergency room so my mother don't stay so long the next time? Are you going to do these things, right? So don't just come to me and get data, but are you a real advocate? Are you intervening on our behalf? So I would say that that's give you the kind of credibility to go and sustain some of this work. We also did, and just the issue of what we did in our presentation, statistic is sometimes remove people from understanding communities. We go in and talk about the real communities. What is that reality? How they're feeling, and to address it, because too often people doing research and designing deal with cold statistics. They never feel, they never seen, they never touch. And that's become a factor. They don't really have live read community engagement. We always try to bring that to the table. The COVID-19 pandemic really forced a different type of conversation and allow a lot of us to be on the table in many discussions that we're absent before. Faven, if you want to share some more things.
I think you started to talk about it, is that while we are responsible for sourcing our own funding, largely independent of academic institutions, community members don't care, right? So if you go in and you conduct this initiative, you start this program, the conversation then becomes, when can we do this again? And we can't say, well, this is only funded until September, right? They're saying, well, you just made this something that was important to me. You brought in my family, my church, my clients. And so there's a level of accountability for us to continue that process, to sustain the work. And so sometimes it's not easy. UNICEF didn't fund part 2 or hasn't funded the work since then, right? Because they have their own limitations. And so it becomes the responsibility of the Institute to ensure that sustainability remains a centerpiece of our work.
Humberto, I think you're on mute.
To Stella, that the issue of networking, that's very important. And when we created a community group, right, that was very important because most of the community groups were having a hard time on their own. Everyone competing with each other, making small grants. I think that's the agenda of the day. So I don't know what kind of network you all belongs to, but our Community for Health Equity, know that we're doing the second part of this health district issue from the state and the city. We're making sure we're fighting, we're organizing, we're pushing to make sure a portion of those $13 billion go to community engagement, go to bringing in those community underground, because people use those community, but they don't leave any resources to sustain that work. So I would recommend something highly to get into some of the sustainability of your work by advocating for community engagement beyond the specific of the type of work that you do. Because we also had to, people recognize us as a leader of 2 of these major network, but it takes a lot of work and a lot of commitment to believe in collective participation. Mm-hmm. And we learning ourselves to protect our work, to be solidarity with each other, with supporting each other, to recognizing each other's work, to make sure that they get the appropriate funding. So I would highly recommend, the type of network for advocacy, for policies, and for resources.
Yeah, I think a lot about civic engagement in healthcare for this exact reason that, oftentimes we can't make a change if we're not thinking about where these policies are driving some of the health inequities that we're doing. And so I would invite you all that if there are letters that we can sign, motions that we can support, just let us know so we can show up, because you're exactly right, Humberto, that so much of this work actually moves by numbers. Being able to say we have a group of 500 clinicians behind us, 500 community members, whatever it is, I think you can really rely on us from within this setting to really be able to support. I want to invite others to please chime in if there are questions that you have. And while folks get ready to do that, I will just say one thing that I'm curious about, and this is my perspective as a clinician, is how would you, I guess, say to traditional mental health services that are more located within health systems, within clinics, what would you say to them about thinking about partnering with this kind of community-based mental health model? Tips or things that they should, folks that do that work from within a health system lens can think about or should think about to be able to support this kind of a program?
Yeah, I think through this work and other avenues of our work, we learned that everybody has their area of expertise, right? So we are not mental health providers. I'm not a psychologist, I'm not a counselor, but I am a public health advocate. I am an educator. And so it's collaborating, recognizing what our strengths and our weaknesses are, and thinking about how we can supplement and support one another. And I think that that's largely what we did with a lot of this work with mental health. And a lot of the work that we do at the Institute is just establishing, okay, we are not experts in this field, or we don't have this type of training, or we're not certified in this, but who in our community do we know can do that? And so I guess coming to partnerships from that perspective of thinking about how we can be mutually beneficial to one another is an important approach.
And we do a lot of search looking for community-based organization that has the kind of same compatible values for this work. I mean, we really went through to find good social workers who understand racism, people who understand police brutality in our communities. So when we brought them as a health professional, they already was aligned with some of the issues that we are trying to address. We had excellent mental health professionals who understood the impact of slavery and the legacy in our communities, and that the approach of treatment and healing include those things. So what Faven was saying earlier, and prior Kenya, when we were looking for people, we kind of align people who have some of the same values, who are doing some of the same type of intervention. And so it become a network of people who have designed with intentionality to approach healthcare and health delivery in a different way.
Well, that is excellent. I want to kind of give you all the platform to leave us with any final words of wisdom as we come to a close. I'll start with you, Faven.
Oh, words of wisdom. That entire presentation.
Yeah, just what I said.
Yeah, I think I would just recommend continuing to find spaces where community voices can exist in whatever setting, capacity you're in. There's that can happen in curriculum development. It can happen in when you're teaching and bringing community-based organizations like ourselves into these types of settings. They can happen on executive committees, on community advisory boards. I think there's a lot of different ways that currently exist or may not, but I would just advocate for integrating community voices.
That's excellent. And Kenya and Humberto, would you add anything?
I will say what I said earlier, be courageous. I think one of the problems that we face a lot of professionals is that we allow the institution to impose language and concept, and we fail. We write it in an article, but we don't want to talk about racism. And now that there's a backlash against addressing racism in this country, of being anti-racist, we have to be courageous. If I'm in a room, the issue of racism is going to happen. If a woman, a Black woman, a gay person, the difference is that if you're in the room, it should make a difference. I think that matters. I also think that we should talk truth. Sometimes we use a lot of terminology as I try to unpack why we use those terms initially. For like people talk about diversity, like diversity guarantee equity, and it doesn't. Diversity, you have all the doctors are white and all the cleaners and the other people are but minorities. They're in the same, there's diverse but not equal. It's diverse. Diversity doesn't always reflect. The diversity that is important for us is equity, that in each of the areas you have representation of the total population, and that only comes with intentionality. And I just think that is important. I can tell you for being an activist that community trusts you if they believe that you're a truth teller, that you go in there and you just don't repeat the same story. And I think this time to open doors in that way, specifically in research. We have a lot of challenges where people want to do the same thing. They don't want to approach certain issues, and you can't do it today. I'm just happy to know that people are doing it a worldwide intersectionality, looking at what is the difference in India or South Africa, New York, or to understand the complexity of these new approach to multiple population with multiple system of oppression. So that's my recommendation, that we just be courageous, because we know most of the things. Sometimes we just don't feel that we look for safe spaces, and sometimes we have to transform unsafe spaces and safe spaces for our voices.
In closing, I think one recommendation, just to this lesson learned, is that navigating a lot of these topics, just a lot of these from the youth, that we really learned that navigation can be really hard. Navigating to like self-care, just navigating within the healthcare system. So just really be important to be intentional and just to really follow up into what the community needs. And then especially just meeting the community where they're at. I think a lot of times, as Faven mentioned, we work with youth from 12 to 24. And so everyone needs different things. And sometimes a 12-year-old doesn't understand topics that you're trying to explain to someone who's 18, or just even thinking about working with elders or adults. Like everyone has different needs. So it's very, very important that we think about when we're navigating people, that we navigate them to what they need and just being flexible.
You all are amazing. I love just the reminder to be courageous. And I feel like we should all be hearing that voice when we are in the room, so that it does make a difference. Thank you, thank you, thank you for being here, for sharing this real world experience with us and showing us what is possible. I am going to share with those that are on kind of our next steps going forward. So we are encouraging you to please fill out the feedback survey. We kind of make these and turn these into what you want to hear. Again, this came from Paulette, who was like, they would be amazing for rounds, and you all were. And so fill out our feedback surveys. Let us know who you'd like to hear from. If you have questions and want to see work from previous rounds, you can access it at the previous rounds site that I shared earlier, and the link is here. And please remember that our next rounds will be March 28th, Tuesday at 4:30. And you can go ahead and register in the link that we put in earlier. And just thank you all for being here. As always, it's always fun to spend this time with you and get gems dropped so we can think about how we do our work outside of the walls of the health system. So thank you all, and we'll see you next month.
Thanks, everyone.
Thank you.
Thank you.
Bye.
Bye.